This recorded lecture will be going over Chapter 28, Care of Patients with Disorders of the Upper Gastrointestinal System. Anorexia nervosa is classified as a psychological disorder, but it has serious nutritional consequences. A patient with anorexia nervosa will refuse to eat adequate quantities of food, and they're in danger of literally starving to death. Diagnosis requires extensive interviewing and treatment, including behavior modification and nutrition support. This can take months to years. A person who has bulimia nervosa consumes large quantities of food and then induces vomiting to get rid of it so that weight is not gained. Laxatives can be taken to purge the system after an eating binge. Some patients with anorexia nervosa also have bulimia nervosa. When it is practiced frequently, it can lead to severe fluid and electrolyte imbalances, starvation, dental problems, and death. Treatment of bulimia includes psychotherapy, antidepressant medication, and behavior modification. More than 40% of adults in the United States are obese, as defined by a body mass index or BMI of 30 or above. Obesity is a known risk factor for cardiovascular disease and associated death. Children are now showing a continued trend for increasing obesity. Several factors must interact for obesity to occur: a diet of foods high in calories and fat, a lack of exercise, and overconsumption of food. Known contributors to obesity include readily available high-calorie prepackaged foods, the prevalence of high fructose corn syrup in foods, consumption of sodas, and high-fat fast food, as well as supersized portions available in restaurants. The way a person develops fat cells and deposits fat is another factor in obesity. Family lifestyle is most likely a factor because obesity seems to occur among family members. A person is considered obese if they weigh more than 20% above the ideal weight for their height, age, and body type. Approximately 3 million Americans are severely or morbidly obese, meaning that they are 100% above their ideal body weight or have a BMI greater than 40. Complications of obesity include diabetes mellitus, hypertension, hyperlipidemia, coronary artery disease, obstructive sleep apnea, cholelithiasis, cancer, arthritis with back or knee problems, and an increased susceptibility to infectious disease and decreased wound healing. To determine whether a patient is obese, the following measurements are used: height and weight from a chart. If the patient is more than 20% above their ideal body weight for their age and body build, they are considered obese. You should measure the waist and then the hip circumference. Calculate the waist to hip ratio. If the ratio is more than 1.0 in men or 0.8 in women, it indicates the person is overweight. A BMI of more than 30 indicates obesity, and you can see the way to calculate BMI on page 663. Thyroid function should be determined to confirm that hypothyroidism is not a cause of the weight gain. Dietary control and exercise are the main treatments for obesity. The patient will be taught ways to change their thinking about food and weight. Those with a BMI greater than 40 can have surgery to achieve weight reduction if they meet established criteria. Teaching stress reduction and alternate ways of coping are essential to success. Medications that suppress appetite or block fat absorption can also be used on a short-term basis. Orlistat inhibits lipase and causes fats to remain partially undigested and unabsorbed. Phentermine topiramate has also been found to be safe for up to 2 years of usage. Naltrexone extended release or bupropion extended release is an appetite suppressant that interacts with many depression medications. It can be used as an adjunct to dietary modifications. These drugs should not be used during pregnancy. Bariatric surgery can be considered when the BMI is greater than 40 or BMI is 35 or greater with one or more obesity-related complications. The patient must agree to modify their lifestyle and follow a stringent regimen required to lose weight and then keep that weight off. Three common types of bariatric surgery include gastric restrictive, malabsorptive, and gastric restrictive combined with malabsorptive surgery. The most commonly performed restrictive surgical procedure is laparoscopic sleeve gastrectomy, or LSG. In this procedure, a portion of the stomach is removed, leaving a banana-shaped pouch. This restricts the amount of intake. Adjustable gastric banding is another laparoscopic procedure that can be performed by placing an inflatable band around the fundus of the stomach. These images can be seen on page 664. The Roux-en-Y gastric bypass, or RYGB, limits the stomach size, and the duodenum and part of the jejunum are bypassed. This will limit the absorption of calories. With the RYGB procedure, there is a danger of leakage of stomach contents into the abdomen during the early postoperative period. Signs and symptoms of this include abdominal pain, nausea, vomiting, tachycardia, fever, and hypotension. RYGB patients are also at a high risk of dumping syndrome. This results in nausea, weakness, sweating, and diarrhea that occurs after meals. Other complications of major surgery could occur in the respiratory and cardiovascular systems. Patients who are obese have a greater risk of pulmonary dysfunction, thrombus formation, and death. Approximately 1/3 of all patients who undergo bariatric surgery will develop gallstones due to their rapid weight loss. All bariatric surgery patients are at risk of nutritional deficiencies, and supplements must be taken for life. Data collection will include establishing whether there is a family history of obesity, determining contributing factors, and obtaining an accurate record of eating patterns over a 7-day period. The diet and exercise plan should be designed according to the patient's lifestyle and preferences. Encourage the patient to keep an eating and exercise diary. Offer support by being available to talk about the positive aspects and frustrations of staying on the diet. Weight Watchers and TOPS are two commercial programs that have shown good long-term results with maintenance of normal weight. Preoperative and postoperative care for a patient having bariatric surgery will depend on the type of surgical procedure performed, but general principles will be similar to those for other types of abdominal or abdominal laparoscopic surgery. Feedings are designed in consultation with a dietitian. You would anticipate feeding progression in the early post-op period, then moving to multiple small meals, a balanced meal plan, and possibly parenteral nutrition in high-risk patients. The diet will be maintained for 6 weeks and then progress to regular foods. Nausea, vomiting, and discomfort can occur, especially if too many liquids are ingested. Sugar in any form should be avoided, as are concentrated sweets like fruit juice. All juice should be diluted. Concentrated sugar can cause dumping syndrome. Supplementation with multivitamins, calcium, vitamin D, and vitamin B12 should be taken routinely. The patient's diet and exercise diary should be evaluated every week if possible. Bariatric surgery patients will do best with group support. Stomatitis is a generalized inflammation of the mucous membranes of the mouth. Causes include trauma from ill-fitting dentures or malocclusions of the teeth, poor oral hygiene, and nutritional deficiencies. Excessive smoking, excessive drinking of alcohol, pathogenic microorganisms, radiation therapy, and drugs are other contributors to this problem. Common symptoms of stomatitis include pain and swelling of the oral mucosa, increased salivation or excessive dryness, severe halitosis, and sometimes fever. Canker sores can appear in the mouth. Treatment of stomatitis is chiefly symptomatic unless a specific causative agent has been identified. Dysphagia means difficulty swallowing. It can vary from a mild sensation that something is sticking in the throat to a complete inability to swallow solids or liquids. Tumors, esophageal diverticula, inflammation, or motility disorders from a neurologic disorder can all cause swallowing problems. If the patient is experiencing choking or difficulty with swallowing, they should be kept on an NPO status and swallowing ability evaluated by a bedside nurse or speech therapist. If additional information is needed, a modified barium swallow test can be ordered to determine the specific cause. Video fluoroscopy can be used to determine and visualize the swallowing process. Have the patient take some practice swallows before they begin a meal or giving any oral medications for the first time. Watch to see that the larynx rises with each swallow. Measures that can be helpful in relieving dysphagia include instructing the patient to chew food more thoroughly or to eat semi-soft or pureed foods. Liquids can cause many patients to choke. If thin liquids are a problem, adding thickener to the liquids will make them easier to swallow. Sitting upright with the head forward and the neck flexed, with the chin slightly tucked, can aid in swallowing. A speech pathologist should be consulted to design the most effective therapy for the patient. The patient may be a candidate for neuromuscular electrical stimulation, or NMES. One type of NMES device will stimulate the muscle at rest. This can compensate for muscle wasting. Another NMES device can be used for patients with swallowing issues related to neurologic disorders, like strokes. Both acute and chronic dysphagia are likely to produce nutritional deficiencies and electrolyte imbalances. Tube feeding may be indicated. This can sometimes be necessary when the dysphagia is the result of cerebral damage, like in a cerebrovascular accident. If the patient cannot swallow anything due to a neurologic condition, or if the esophagus is obstructed and cannot be corrected surgically, the patient must have a gastrostomy tube placed. Oral or throat cancer is curable if discovered early. Oral cancers are primarily squamous cell carcinomas. A genetic factor is most likely present. Oral and pharyngeal cancer risks include cigarette smoking, the use of smokeless tobacco, pipe smoking, and heavy alcohol use. Infection with the human papillomavirus, or HPV, is another risk factor. Leukoplakia, a precancerous lesion, could occur on the tongue or mucosa. Any sores or discolorations on the lips or mouth that do not heal within 2 weeks should be checked by a healthcare provider. The mnemonic RULE, which means red, ulcerated, lump, and extending for 3 or more weeks, will identify the need for further testing. Diagnosis can be made by physical examination or biopsy. Surgery and/or radiation are the most common treatments. A mandibulectomy, which is the removal of the mandible, a hemiglossectomy, which is a removal of half of the tongue, or a glossectomy, removal of the entire tongue, with resection of other parts of the mouth may be necessary. A tracheostomy will accompany all these procedures to protect the airway. Tube feedings will be used for as long as swallowing is difficult. Postoperative care includes close monitoring of respiratory status, airway, and oxygenation. Cold packs and elevation of the head can prevent excessive swelling in the neck that could compress the airway, circulation, and nerves. Nutritional support is an ongoing concern and is very important in the healing process. Cigarette smoke and alcohol will both irritate the mucosa of the esophagus. In the decades since the 1970s, reflux has replaced tobacco and alcohol as a primary irritant, leading to adenocarcinoma of the esophagus. GERD is a cause of Barrett's esophagus, which is a precancerous condition. Care is focused on measures encouraging the prevention of GERD and on regular checkups. Periodic endoscopy and biopsy will be performed for those showing dysplasia in the esophagus. Signs and symptoms of esophageal cancer can include progressive dysphagia, hoarseness, regurgitation of foods, foul breath, and persistent cough. At first, the dysphagia occurs only with solids like meat, but then it will happen with soft foods and eventually even liquids. Weight loss is typical. Definitive diagnosis is done by EGD and biopsy. Appropriate treatment will be decided based on the stage and type of cancer. Localized lesions can be removed with endoscopic mucosal resection. Other treatment options include endoscopic ablative therapy, like photodynamic therapy, radiotherapy ablation, or chemoradiation. An esophagectomy, or removal of secretions of the esophagus and reconstruction with part of the stomach, can be performed with extensive disease. For patients who have advanced stage cancer, palliative care may include a combination of external beam radiation, chemotherapy, esophageal dilation, electrocoagulation, photodynamic therapy, and the insertion of expanding metal stents to relieve severe dysphagia. Postoperative care is the same for any patient having a gastroendoscopic, thoracic, or abdominal surgery, depending on the surgical procedure. Maintaining a patent airway is the top priority. Nursing interventions will focus on promoting adequate respiration, providing a way to adequately communicate, ensuring adequate nutritional intake to promote wound healing, and attention to pain and discomfort. The patient should be upright when eating to prevent regurgitation. After esophageal resection, pain, increased temperature, and dyspnea may indicate the leakage of feeding into the mediastinum. Intolerance of food can be evidenced by vomiting and abdominal distension. If these symptoms occur during a feeding, you should stop the feeding. The patient may need a feeding tube for several weeks or a gastrostomy tube to sustain their nutrition. A loss of muscle strength and tone, factors that cause increased intra-abdominal pressure, like obesity, ascites, or multiple pregnancies, and congenital defects will all contribute to the formation of a hiatal hernia. This will create a protrusion of part of the stomach or the lower part of the esophagus up into the thoracic cavity. Often there will be no signs and symptoms of a hiatal hernia unless there is reflux of stomach acid. Signs of reflux include indigestion, belching, and substernal or epigastric pain, as well as feelings of pressure after eating caused by the reflux of gastric fluid into the esophagus. These symptoms will be more severe when the patient lies down. Hiatal hernia is diagnosed by an upper GI series. Treatment includes weight reduction, avoidance of tight-fitting clothes around the abdomen, administration of antacids, histamine or H2 receptor antagonists, or proton pump inhibitors, also known as PPIs. Elevating the head of the bed 6 to 8 inches will also help. An intake of alcohol, chocolate, caffeine, and fatty foods should all be limited, and smoking should be avoided. If weight is above normal, encourage weight reduction. Remind the patient to stay upright for 2 hours after eating and not to eat 3 hours before bedtime. Lifting or moving heavy items should be avoided. Prescribed H2 receptor antagonists, or PPIs, should be taken at bedtime to prevent reflux and damage from acid entering the esophagus. The patient should avoid foods that cause bloating, which can increase abdominal pressure. GERD is a syndrome, not a disease. GERD occurs equally in men and women. It is caused by a transient relaxation of the lower esophageal sphincter and can accompany a hiatal hernia. Being overweight is common among patients with GERD. About 75 patients with asthma will also have GERD. Heartburn, also known as dyspepsia, and reflux are the most common symptoms of GERD. Other symptoms can include chest pain, coughing, dysphagia, belching, flatulence, and bloating after eating. All of these symptoms will be aggravated by lying down. GERD is diagnosed by the common clinical symptoms. If more alarming symptoms like dysphagia, anorexia, or upper GI bleeding are present, an EGD will be performed. On page 669, we can see in the blue patient teaching box some measures to decrease the symptoms of GERD. Diet therapy, lifestyle changes, particularly weight loss for those who are overweight, drug therapy, and education are the mainstays of GERD treatment. Drug therapy can include antacids, H2 receptor antagonists, PPIs, and prokinetic drugs. Verify that the patient can afford the drugs prescribed because some will be very expensive. Laparoscopic surgical fundoplication, in which the fundus of the stomach is wrapped around the esophagus to create a new valve junction, may be effective. This is the same procedure that will be used to correct a hiatal hernia. Constant irritation can cause cellular changes, like the precancerous lesions found in Barrett's esophagus. Reflux is also a risk factor for aspiration of stomach contents and pneumonitis. Acid reflux into the mouth over time will cause dental caries. Gastroenteritis is an inflammation of the stomach and small intestine. It is caused by an intake of food or water contaminated with a virus, pathogenic bacteria, or parasites. It is diagnosed by the clinical signs and symptoms of vomiting, diarrhea, abdominal cramping, mild abdominal tenderness, and distension. In healthy adults, the disorder is self-limiting and does not require hospitalization. A patient with gastroenteritis should be kept NPO until vomiting has stopped. When tolerated, fluids containing glucose and electrolytes should be started, but fluids with a high sugar content like soft drinks or fruit juices should be avoided. After 24 to 48 hours, medication can be prescribed for the vomiting, abdominal cramping, and diarrhea. The main cause of chronic gastritis is Helicobacter pylori bacteria, also known as H. pylori. But other bacteria, viruses, and parasites can also be the cause. Contributors to acute gastritis and gastropathy include drinking excessive amounts of alcohol, infection from eating contaminated food, cocaine use, and the ingestion of medications such as corticosteroids and NSAIDs. Gastritis is not a disease. It is an acute or chronic inflammation of the mucous membrane lining the stomach that causes changes in the tissue. Gastropathy is a similar disorder where changes to the lining of the stomach will occur without the inflammation, usually a chemical process. A tissue biopsy will be needed to make the distinction. Untreated chronic gastritis can progress to ulcer formation and upper GI hemorrhage. The main symptoms include anorexia, nausea, vomiting, pain, and tenderness in the stomach region, hiccups, and sometimes diarrhea. Diagnosis will be made by history, physical examination, and endoscopic examination. Acute gastritis is typically of very short duration. Treatment will consist of withholding all foods by mouth and administering drugs that slow the peristaltic action of the GI tract. Patients with gastritis should be watched closely for signs of fluid and electrolyte imbalance. Treatment for chronic gastritis will consist of antispasmodics to decrease the pain of stomach spasms, antacids, and an H2 receptor antagonist like ranitidine to decrease acid secretions and change the pH, or a PPI to decrease the secretion of hydrochloric acid. All NSAIDs and substances known to cause gastritis should be discontinued. Chronic gastritis is not as easily treated as acute gastritis. Patients with chronic gastritis should not eat any spicy or acidic foods. H. pylori infection with the use of NSAIDs is the major cause of peptic ulcers. Smoking, stress, and physiologic factors are other causes. H. pylori is rich in an enzyme that can cause corrosion of the coating of the upper GI mucosa, making it more susceptible to damage from gastric acid and pepsinogen. Gastric ulcers Gastric ulcers do occur in those who are poorly nourished due to poverty or poor eating habits. There is a greater incidence of ulcers in low-income workers. Stress will have a bearing on the progression of a peptic ulcer. Tension, anxiety, and prolonged stress all alter gastric function. A stress ulcer is pathologically and clinically different from a chronic peptic ulcer. It is typically more acute and more likely to produce hemorrhage. Stress ulcers are a hazard for patients who are severely ill and in intensive care units for prolonged periods of time. Such patients will typically be receiving medication to prevent ulcer formation. Drug-induced ulcers are most commonly caused by aspirin, NSAIDs, biphosphonates, alcohol, and glucocorticoids. Ulcers will develop when the mucosa cannot protect itself from corrosive substances like gastric acid, pepsinogen, alcohol, bile salts, and irritating food substances. A peptic ulcer is an ulceration with a loss of tissue of the upper GI tract. This term includes both duodenal and gastric ulcers. Symptoms of uncomplicated ulcers include epigastric pain that can be described as burning, gnawing, cramping, or aching, typically coming in waves and lasting for several minutes. With a gastric ulcer, the pain is diminished in the morning when secretion is low and after meals when food is in the stomach. The pain will be most severe before meals and at bedtime. Other subjective symptoms include nausea, loss of appetite, anemia, and weight loss. Signs of acute GI bleeding include complaints of weakness and feeling faint, nausea and vomiting, restlessness, thirst, and mental confusion. Hematemesis, or the vomiting of bright red blood, will indicate an active bleed. Blood that has been sitting with gastric juices looks like coffee grounds. Diarrhea, decreased blood pressure, rapid pulse, and other signs of hypovolemic shock can occur. If bleeding from the upper GI system is profuse, maroon or bright red blood can appear in the stool due to the rapid transit of blood through the intestinal tract. Black stools almost always indicate the presence of digested blood, which means that the source of the bleeding is in the upper GI tract. Estimates of blood loss from the GI tract will be based in part on the blood pressure readings and pulse rates. Therefore, they should be monitored every 15 to 30 minutes whenever there is evidence of extensive GI hemorrhage. Hemoglobin and hematocrit levels are useful in determining the status of patients with GI bleeding. The white blood cell count may be elevated in massive GI bleeding due to the body's inflammatory response to injury. Peptic ulcers will be diagnosed by endoscopy. This can locate the site of ulceration and the bleeding. EGD will allow for biopsy samples to be obtained and for treatments to be delivered. Testing for the presence of H. pylori is essential. This testing can be done during an EGD, by blood sample, or by breath test. When a patient is experiencing extensive GI bleeding, their condition must first be stabilized, and then diagnostic procedures will be performed to locate the source of the bleeding. Such procedures would include endoscopic examination of the esophagus, stomach, and small intestine. Peptic ulcer is initially treated with medication. Surgical treatment will be used when conservative treatment has not been effective. Medications to relieve pain from local irritation of the intestinal mucosa include antacids and PPIs, which both decrease gastric secretions. Endoscopy is routinely performed to identify the source of bleeding and, if indicated, to treat it. During the endoscopy, bleeding sites may be treated with thermal coagulation or the placement of hemoclips. PPIs will be given IV or orally to decrease or stop acid secretion. These treatments will be effective in stopping the bleeding 80% of the time. The other 20% will require surgery. Maintenance of fluid balance is extremely important. Intake and output must be measured and recorded accurately. Oxygen therapy will be started to maximize tissue oxygenation. Adequate IV access must be maintained. Eliminating H. pylori with antibiotics is first-line treatment. As well, gastric acid will be reduced with PPIs. The three major complications of peptic ulcers include hemorrhage, perforation, and obstruction. Signs of hemorrhage include vomiting blood. Perforation is the erosion of the ulcer through all the walls of the stomach or intestine. This constitutes a surgical emergency due to the danger of hemorrhage and peritonitis. Perforation will be characterized by a sudden, severe pain in the upper abdomen that persists and increases in intensity and can sometimes be referred to the shoulders. The abdomen will appear rigid and board-like and will be extremely tender. Obstruction will occur as a result of scarring and loss of musculature at the pylorus, narrowing at the stomach outlet, and can be manifested chiefly by persistent vomiting. Surgical treatment becomes necessary when a chronic ulcer fails to respond to medical or endoscopic treatment, when complications like perforation, obstruction, or hemorrhage have occurred, or when malignancy is present. In pyloroplasty with truncal or proximal gastric vagotomy, the pylorus, which has been narrowed by scarring, will be widened. Subtotal gastrectomy, or a gastric resection, will consist of removing a part of the stomach and then joining the remaining portion to the small intestine by anastomosis. Anastomosis is the joining of two hollow organs by suturing the open ends together so that they become one continuous tube. An antrectomy, in which the gastrin-producing portion of the stomach, known as the antrum, is removed. This can be done in conjunction with a truncal vagotomy. A total gastrectomy is the surgical removal of the entire stomach. Preoperatively, an NG tube will be inserted, and all stomach contents will be suctioned out before the surgery. The patient will undergo routine preparations necessary for all major abdominal surgery. If the patient has had a barium enema, look for and report stools containing a whitish material. This whitish material is barium, and it will become hardened if left in the colon, thus presenting the possibility of fecal impaction later on. Postoperatively, care of patients who have had gastric surgery is routine, but there are some exceptions. Care must be taken in handling the NG tube to prevent injury to the sutures and to prevent introduction of infectious agents. After the tube has been removed, the patient should be given small amounts of liquid to determine their tolerance. If these liquids are well tolerated, the patient can progress to small, frequent feedings. Within 6 months, most patients can then take 3 regular meals per day. Patients who have had a total gastrectomy are typically restricted to small, frequent feedings of easily digested semi-solids for the rest of their lives. Some patients who have had a gastrectomy or who are started on a full-strength tube feedings will experience a complication known as dumping syndrome. The patient will have nausea, weakness, abdominal pain, and diarrhea. They may feel faint and perspire profusely or experience palpitations after eating. This will occur because part or all of the stomach and duodenum has been surgically removed. The patient with dumping syndrome should be taught to avoid eating large meals and to minimize fluids during the meal. The patient should try to avoid sugary foods or snacks, and it can also be helpful for the patient to lie flat for 30 minutes after a meal. Before a peptic ulcer can be successfully controlled, the patient must understand how and why the ulcer developed in the first place. You should observe skin color, observe for diaphoresis or thirst, and look for any other signs of continued blood loss, like restlessness. Melena stools are black, tarry stools with digested blood. They will cause an unpleasant odor, and the room should be kept as free of odor as possible. Diet counseling is a top priority once the patient is stable. Currently, most authorities believe that it is best to restrict only those foods that the patient identifies with the onset of symptoms. The patient will be instructed to eat at frequent and regular intervals, and meals should not be skipped. Alcohol and caffeine should be excluded. You can point out any signs of improvement to the patient that will help relieve their anxiety. Stomach cancer is usually discovered very late because patients will often lack symptoms. The cause of gastric cancer is unknown. Pernicious anemia and achlorhydria, or the absence of hydrochloric acid, are often present as an outcome of autoimmune disease. It is also believed that a diet high in smoked, highly salted, or preserved foods can be a contributor. H. pylori is identified as a carcinogen. Alcohol use and tobacco smoking are both linked to gastric cancer. All of the causative factors alter the tissue lining of the stomach and will end up with the same result: abnormal cells that produce a cancerous growth. Gastric cancer is usually asymptomatic until the disease is far advanced. Signs and symptoms can include indigestion, loss of appetite, nausea, vomiting, and weight loss, but these can be limited to just intermittent abdominal distress. The patient may become pale and weak and complain of fatigue, dizziness, weakness, and sometimes shortness of breath. Anemia is the underlying cause of those symptoms, and there will often be blood in the stool. Diagnosis can be made by an upper GI series and endoscopic examination of the stomach with biopsy. CT scans of the abdomen and pelvis can help with staging so that appropriate treatment can be initiated. Surgical intervention can relieve symptoms like obstruction or debulk the tumor. There is only a 40% 5-year cure rate with surgery for gastric cancer. Radiation has proved to be of value only for palliation. Abdominal distension with increased pressure within the abdominal cavity is very uncomfortable. An NG tube to remove fluids and gas from the stomach can be inserted. GI tubes will vary in their length, design, and purpose. Observe the patient for continuing signs of abdominal distension during the gastric decompression. This would indicate that excess fluids and gases are not being removed as intended. Nausea, vomiting, complaints of feeling full or bloated, increasing shortness of breath, and an increase in the girth of the abdomen are all signs that the stomach and intestines are not being decompressed adequately. Applying too much suction can pull the gastric mucosa into the drainage openings or eyes of the tube. This can cause damage to the mucosa and traumatic ulceration. Unless ordered otherwise, you should always use the low suction setting of 80 to 100 millimeters of mercury. Irrigation of the tube with normal saline is ordered to keep the tube patent. The characteristic of drainage should be charted each shift. If coffee ground-like material is noticed in the tube, the drainage should be tested for the presence of blood using a hemostick strip dipped into the secretions. An NG tube will be uncomfortable for the patient. The nares must be checked for signs of pressure, and the tube may need to be repositioned in the nares to relieve this problem. Common complaints include sore throat, dry mouth, earache, dry lips, and nasal mucosa. After the NG tube has been removed, the patient should be monitored for nausea, vomiting, and abdominal distension. Sometimes it will be necessary to reinsert the tube again. If a patient has a long-term difficulty taking in food orally, as when in a coma or with dysphagia from a stroke, enteral feeding will be indicated. If long-term feeding is needed, a gastrostomy tube or G-tube can be placed. Placement of feeding tubes other than in the stomach can also be indicated when a surgical procedure has altered the anatomy. Small bore flexible tubes will be inserted with a stylet and can usually be positioned with the tip in the duodenum, known as nasoduodenal. Fluoroscopy or post-placement X-ray should always be used to ensure the correct placement. Placement in the duodenum will be confirmed by X-ray film before feedings are started. The feedings can be given at specified times throughout the day or on a continuous basis. If continuous tube feedings are ordered, they will be administered with a feeding pump. Patients who require long-term nutritional support for problems like inability to swallow may undergo percutaneous endoscopic gastrectomy or a PEG tube. The tube will be marked with indelible ink at the point of exit so that correct placement will be checked daily. The area should be observed for signs of infection and cleansed daily with soap and water until healing is complete. Adding a feeding when there is too much residual from the last feeding can cause regurgitation and aspiration. If a patient can swallow and eat but is not able to take in enough nourishment to meet their body's requirements, peripheral parenteral nutrition or PPN can be given to supplement the diet. This IV site will need to be monitored carefully to ensure that the components of PPN have not caused inflammation. If infiltration occurs, soft tissue injury can result. Total parenteral nutrition, or TPN, is indicated when the patient cannot ingest or digest foods normally, or they have a problem with malabsorption. Conditions that could warrant TPN include severe trauma to the intestinal tract, as with a gunshot wound, and chronic inflammatory conditions. TPN is essentially a form of IV feeding. TPN is total nutrition, and these patients can be maintained on IV nutrition for as long as necessary. If long-term use is required, a long-term central catheter, like a PICC line or implanted port, should be placed. On page 683, see the red safety alert box. Infusing an enteral feeding into an IV site can result in death, and this has happened before. Nursing care will include assisting with the insertion of the IV central line, changing the tubing with every new bag or bottle, changing the dressing, observing the insertion site, and removing the tubing when TPN therapy has been discontinued. Day-to-day care will include monitoring vital signs, glucose levels, and the fluid and electrolyte balance. The rate of TPN will be slowly decreased to gradually lower the dextrose load before the TPN has been discontinued.